We have Dr. Abby Girard now joining us on her topic of sexual health matters. Dr. Girard is an assistant professor and coordinator of the Relationship and Sex Therapy program at the Eli Coleman Institute for Sexual and Gender Health here at the University of Minnesota. She received her master's from the University of San Diego and her psychology degree from the Alliant International University in both marital and family health. She has several areas of interest, including sexual health and functioning, sexual desire discrepancy, and among other clinical practices, she treats individuals and couples with intimacy concerns. Thank you so much, Dr. Girard, for joining us today.
Sure. Hello. Okay. I always get kind of messed up with this. Okay. Do we want to wait? It seems like people are coming in. Do we want to give people a couple minutes to? Okay, cool.
We'll just keep moving.
All right. We are going to spend the next, 30-40 minutes talking about sex. Woohoo. Okay. So, let me see here. So we are going to talk in the kind of the beginning part here about kind of what's happening. And a lot of this, I hope, is overview for everybody. And then we're going to talk about the impacts of different treatments on sexual health, and the kind of big chunk is going to be the strategies to use to kind of address these changes. Whoa. Okay. So as most, if not all of you know, sexual function changes a lot kind of before, during, and after cancer. And it can vary a lot for each person, depending on things like kind of what their sexual health and relationships were like before cancer, what types of treatments they had, and side effects, and kind of all of that. So what we know from kind of all of the research is that typically patients don't bring it up, and providers also don't bring it up. And so there's really a lack of that. And so I guess I'm really curious, show of hands, how many of you had conversations with anybody on your care team about sex? That's way more than I expect. How many of you brought it up? Okay. I rest my case. And so a lot of what I do is try to teach providers, but then I also work, that's kind of the research, and then the clinical stuff, I work with people, typically in survivorship, about how to address everything that has changed. And so sexual health can be the function, but it can also be how you view yourself as a sexual person, how you relate to your body, and kind of how you engage in intimate relationships or not. And so it can impact kind of all aspects of yourself, not just the physical, but also kind of the relationship and relational and psychological pieces of that too. And so we know that sexual health is kind of a fundamental human right, and something that regardless of age or life stage is kind of an important piece of our quality of life. I do want to kind of give the caveat that throughout the presentation, I'm referring to women because that's the majority of people diagnosed with breast cancer. However, and I want to acknowledge that the research tends to lack around sexual and gender minority folks that have breast cancer. And so while we are using that language, I do want to kind of recognize that that might not apply for everyone. So in terms of the basics, the majority of people are diagnosed at an early stage, right? And what we know that perhaps is important, just looking on the kind of long infographic, is around the subtypes. And so the majority of people, so at least 70%, have a hormone receptor positive breast cancer. And that's important based on the treatment. And so that's just kind of to catalog for later as we're talking about the impact of certain drugs and things like that, okay? And so again, I'm sure that this is not new information, but it's a good kind of reminder that it's super common, often diagnosed at earlier stages, although that can be quite variable. And the survival rate it continues to be very, very high, which means that we are living in survivorship or a lot longer as survivors dealing with the long-term effects of the treatments. So in terms of the common treatments, right, we have 2 that are local and the rest that are systemic. And so we have surgery and radiation, which are going to be local to the breast area. Then we have the hormone therapy, chemotherapy, and targeted therapies, which feel like they're changing every day. And so in terms of the side effects of the surgery, it's going to be dependent on the type of the surgery that you have, of course, but that could be the chest pain and tightness, lymphedema, nerve pain, and impacts related to the reconstruction. So for some people, it's a multi-stage surgery. For some people, there's kind of longer-term impacts related to reconstruction, if that's the choice. For the psychosocial changes, right, there's a lot of changes in the relationship in terms of how you relate to your body, how your partner might relate to your body. Almost everybody that I work with clinically has concerns related to how they view their body. And there's a lot of changes to sensation, right? Whether you had a mastectomy and you spared the nipple or not, right? That might make a big difference. And in terms of sex, I can't tell you how often I ask somebody, were breasts a part of kind of how you felt aroused? And nobody ever asked that before. And so it was a conversation that was introduced. And a lot of times there's grief and loss with that are otherwise kind of unacknowledged, right? So in terms of radiation, while not everybody gets it, a lot of times I think the biggest issue that I see in terms of kind of sexual impacts are going to be there might be pain and numbness, swelling, and things like that. Also, if there's lymphedema there, right, then that can kind of contribute to the body image piece. And again, this is going to be quite variable. Chemotherapy, the side effects of that are a lot, right? And sometimes we underestimate what's changing with that. And so depending on the age that you were diagnosed, whether pre or postmenopausal, for premenopausal women, chemotherapy almost always causes what is referred to as chemopause, right? Which will stop menstrual cycles. Sometimes they resume, sometimes they do not. It's very inconsistent, but it also causes, a lot of other concerns that will then, I think that we can often talk about fatigue, we can talk about neuropathy, hair loss, right? A lot of the more common things, and identify that, oh, that might impact how I feel about myself, how much I want to engage with a partner, how I negotiate some of that. And so while it might not be directly related to your sexual function, it does have those broader implications, right? It's kind of hard not to. In terms of the targeted therapies, this is an area that I think as providers, it becomes kind of a black box because the therapies are continuing to change and evolve, and which is wonderful in terms of treatment and kind of long-term disease-free progression. However, a lot of the side effects are kind of question marks, right? And so whether there's fatigue, cough, nausea, oftentimes what I see clinically is, oh, well, I've had these 3 different treatments. And I said, well, it's hard to know which one caused which side effect and how. And so it does become kind of a ball of yarn in that way. And then the last one is going to be the hormone therapy. And so again, show of hands, how many people are on some kind of hormone therapy? Okay. And so this is probably not news to you, right? So the current practice is that if you have a hormone positive breast cancer, you are on estrogen reducing medication for 5 to 10 years, right? It was 5, it's moved to 10, which means that all of these impacts are going to be potentially long-term, right? And regardless of the menopausal status before you were diagnosed, all of the research that we have done has shown that these symptoms are more intense once you've started the medication. So even if you've gone through menopause, then had breast cancer, then you start this, you might experience some of the hot flashes, the sleep disturbance, the vaginal atrophy, things like that again. And so, so now we're going to talk about menopause, because oftentimes that is it feels like the root of so much of what I do. And so here we go. So I thought that this illustration was really great, because every single day that I'm sitting with a woman who is kind of in survivorship of breast cancer, she starts to tell me about her symptoms. And typically, you know, it's a handful of these. And sometimes it's cancer specific, but most often it's a constellation of these. And I'll say, gosh, it sounds like all of those symptoms sounds like something menopause. And it's like, what? So, and a lot of it we don't associate with menopause, right? The joint pain, the frozen shoulder, like a lot of these things where it's like, oh, you know, the brain fog. It's like, oh, no, that was chemo. Well, it might be, but it also might be that there's no estrogen in your body anymore. And so it's really important to have those conversations. And granted, I am a mental health provider, so I recognize kind of the bounds of what I talk about. And right, it is important to recognize that as a care team, we need to be having these conversations to give people appropriate care. And so a lot of, you know, this is, I think, twice as much as most providers will ask about in terms of symptoms and symptom management. And so about 75% of women with breast cancer experience sexual dysfunction in survivorship. Again, variable for a lot of reasons, but that's a very large proportion of people, right? Any questions so far? Comments, concerns? Okay. So in terms of how sexuality is impacted by a cancer diagnosis and the treatment of, it can be based on a lot of different things, right? And so as I kind of alluded to a few minutes ago, oftentimes we don't have a good picture of sexual health pre-diagnosis, again, because nobody's asking. And so we don't really know what it was versus what it is now. I mean, you all probably do, but it's sometimes hard to remember and hard to tell like what caused what. And so the graphic with all the circles kind of shows you all of the different pieces that might go into it, right? So if we have a partner, our previous sexual experiences, whether they were kind of pleasant or unpleasant, our culture, our religion, kind of all of the messages that we received about sex growing up, psychosocial history. So did we have, you know, mental health history, medications, right? Things like that. And then the symptoms and the treatment that are kind of related to the cancer. And so a lot of those different things impact that. Then when you go to the other side, we're also talking about the types of treatments that you received. If there were, you know, if there was hair loss, if there was weight gain or weight loss. So all of the kind of physical impacts that might be peripherally associated with sex. And so I think oftentimes one of the biggest challenges is, when do we talk about sex? And people on the care team, along with you all, give different responses, right? Some people will say, oh, it's always great to talk about. Other people will say, oh, don't talk to me about it until I'm done with all of my treatment. And so from a provider perspective, it's very challenging to know, when is this best to be brought up? What typically happens is that once you have kind of graduated from treatment and you've started to go into surveillance, chances are you're seeing maybe a nurse practitioner or a PA, and that's when these more long-term effects come up. That tends to be what it is. However, we recognize that sexual health concerns can pop up at any given point, right? And so this is kind of the full list of things that can change after cancer. So in terms of sexual function, it's libido or desire, arousal, which is a big one and often related to atrophy and dryness. So changes to orgasm can also occur for a variety of reasons. Dyspareunia means painful sex. Again, that often is associated with that lack of estrogen and that dryness. Ovarian failure. So if you're diagnosed younger, premature ovarian failure can happen pretty consistently, and not just in breast cancer. And then specific things, right? So surgery, that if you have to have surgery that's impacting your sexual organs, your breasts, and altered fertility, again, for people who are kind of in that family planning window. In terms of the psychosocial things that can change, body image, increased depression, anxiety, brain fog, and then changes in the relationship, right? That again, could be related to the sexual health, could also be related to the cancer, could have also been happening prior to a diagnosis. And so that becomes quite nuanced, right? And that's for all of these reasons here. So for a lot of people, this is what desire typically looks like, kind of pre-diagnosis. And then this becomes what it looks like post. And so these are two models of our kind of quote unquote sexual response cycle, where for some people it's linear, right? You have the desire, you get aroused, hopefully you reach an orgasm and you're done. For the majority of women, the more circular response cycle is going to be much more common, where there's all of these different factors, right? It's almost like a list of boxes to check to say, okay, are the dishes done? Is the house clean, right? Do I have to wake up early in the morning? Are we showered, right? Like all of these different things. And so it's like, if yes, continue, right? And so it becomes an emotional intimacy, right? So all of these different pieces then factor into if I'm going to have that responsive desire. So that spontaneous desire of like, oh, I'm feeling in the mood doesn't exist very frequently, right? But it can exist if kind of the stars align or the planets align or whatever it's going to be, right? And so it becomes a lot more nuanced, and often one or both partners has to have that awareness that, oh, it's not that I don't have desire anymore, it's that it looks very different. Again, if I don't have those hormones in my body, or if I just went through all of this kind of trauma to my body, it's going to change pretty drastically, right? And so that's my job, right? I help people kind of figure out how has this changed and what are kind of those keys to unlocking that desire again. For some people, for some people, orgasm changes. For others, it does not. I don't know how many people know this. I should have brought my 3D clitoris, but it broke. Poor thing. So the clitoris is actually kind of looks like this, right? What we see is just a little head on the outside, right? But there are two arms that go on either side of your labia that when you become aroused, get engorged, right? That's what makes sex feel pleasurable. If you are postmenopausal or you are on drugs that decrease the estrogen, that also shrinks the tissue in your vulva, which makes it harder to orgasm, right? So there is a physical reason that that is happening. If you are somebody who has had a hysterectomy, right, that also changes kind of where things live in your pelvis. And so your experience of orgasm can change pretty dramatically there as well. If you are somebody who needed breast or nipple stimulation to reach orgasm or feel appropriately aroused, and then you've had radiation or surgery, that's going to change how you experience orgasm. For some people, thankfully not a lot, painful orgasm is a thing. Very rarely talked about because it is very uncommon, but it does happen. And then of course, like the changes in sensation. That is most often what I hear for people post-hysterectomy. Isn't that it goes away, but it just feels different, right? The intensity feels different. For some, it's better. For some, it's just less intense. This slide is busy, but this is kind of what we see most commonly. So again, when you don't have the estrogen in your body will often, not always, but often go into genitourinary syndrome of menopause, which essentially means because the estrogen has left the body, it goes from that picture of the healthy vagina to the atrophied vagina. So everything kind of shrinks down. which can cause dryness, irritation, pain, urinary symptoms as well. So more frequent UTIs, more frequent incontinence or urgency, and sometimes like bleeding afterwards, again, because the tissue is very thin. And so you may or may not have noticed that that tends to be the most common symptom that is presented to me, along with, I don't have any desire, I don't want to be touched, I don't want to have sex. So those two pieces, which if sex is painful, I wouldn't want to have it either, right? That makes sense. So this is something that often, I think the first line should be addressed with a medical provider, because a lot of the recommendations are kind of in that lane. However, I work alongside folks in survivorship and oncology to manage kind of all the facets of that. This is a graph that just, I think illustrates the differences when you have the estrogen versus not. So all sexual function concerns are exacerbated when estrogen is low. And then the other piece that may or may not be applicable in kind of the breast cancer space, I also work a lot in gynecologic cancer, and so a lot of it carries over. However, pelvic floor health is a big kind of piece of this puzzle. I presented in this very room related to gynecologic cancer not that long ago, and I was really surprised by how many people had questions about pelvic health and pelvic floor physical therapy. So I wanted to include it here, because when there's so many changes related to hormone health and to kind of how your body is responding, inflammation and stuff, a lot of that tension can be stored in the pelvic floor, whether it's hyper or hypo, so really tight or more loose. You can have a variety of symptoms that are related to your urinary, but also your sexual health. And so I know that it is not standard practice in survivorship to provide that referral, but I wanted to bring it up because it is a resource. And we have many clinics and really wonderful providers within our system. In terms of the body image, I don't think I need to kind of drive this home, but there are many facets of that. And it can also be the psychosocial changes. So whether or not you feel like your body has changed all that much, you might feel like your relationship to how you look has changed. And that can be very difficult, right? And you might not feel like there's a lot of places where you can go or people who understand. And so it can be really difficult to adjust to that new normal. I am a marriage and family therapist, and so I often work with the couple in some form or fashion. And so it can be really difficult, right? I don't think I need to go too much into that, but partners can often be afraid. They can have changes to how they feel about the body or the change in appearance of their partner. That can be associated with guilt or shame, right? Or they didn't want to feel a certain way, but maybe they did, and they don't know how to talk about it. I think the biggest thing that I've noticed is that a lot of times if you are partnered when you get the diagnosis, that person almost automatically turns into the caregiver. Sometimes they're great. Sometimes it leaves you kind of wishing they showed up more. Either side of that can have a pretty significant impact. And often it's the transition out of that caregiver role that can be a real challenge for both people, especially if there's kids involved, or if there's just a lot of kind of balls in the air. It can be really hard to kind of renegotiate what is normal. And a big piece I find clinically is helping partners recognize that there are long-term impacts of that care, or of the side effects and et cetera. Last week, I had this conversation with a couple, and the husband just didn't realize, like, oh, she goes through these things every day, because she wasn't saying it, but he just didn't know how to respond, right? And she didn't know how to say, this is still a part of me every single day. I still struggle with the sleep disturbance and the weight gain and the hot flashes and all of the different pieces. And he just didn't know. And he knew nothing about menopause, and he knew nothing about the drugs that she was on. And so we spent an hour saying, well, this is actually what happens. And it made so much more sense and helped him understand and have compassion for her experience in a different way. And that's really what we're talking about, right? Because otherwise he's saying, well, we never have sex anymore, and she's moody, and she's this and that. And it's like, well, but there's a good reason, and let me tell you why, right? And so a lot of that can have pretty significant impacts for a very long time, right? Okay. So this is kind of illustrating, I think, an example of how that cycle can really show up. So in this particular case, the patient thinks that their partner doesn't find them attractive, so they feel less attractive and less open to talking about stuff, and they don't want to show their, maybe I don't want to show my bodies. So then they isolate themselves. The partner takes it personally. They isolate themselves. So neither person's talking, neither person's reaching out, right? And it kind of goes around and around and around. So then we end up not talking, lots of conflict, no sex, no connection. And to be clear, when I say sex, I don't necessarily mean intercourse. I mean whatever you define as sex. So that can be anything. So I think one of the tricky pieces of this is that recovering our sexual health does not mean returning to the way it was. And that can be a really difficult realization for people, and is often met with a lot of grief and sadness, understandably, right? That to recognize that there's going to be a new normal, and one that I probably didn't want in the first place, right? And so we try to adapt and be creative and be flexible, which is perhaps the most fun part of my job, to help people kind of reimagine what a sexual relationship might look like, either with themselves or with partners. And so there's a bunch of different pieces of that. The biological, which of course is going to be your medical care team, the sociocultural, so the community that you're in, if you have support groups, friends, family, that kind of a thing. If you feel like if your work environment feels supportive, and then the interpersonal and psychological are pieces that someone like myself help to navigate. So managing the sexual side effects, here we go. So as I walked in, I saw that there were a couple tables kind of aimed in this genre. So one piece of the sexual side effects is going to be the physical changes. So whether that is hair loss and regrowth, whether that is changes to your chest, kind of post-surgery, if you've had surgery, finding things that make you feel good in your body, clothing, lingerie, if that's something that you're interested in. The far side is something that helps with lymphedema. If you have lymphedema in your arms post radiation and surgery, that's from a company called Lymphedivas, which makes a bunch of really cool stuff. In terms of relationship concerns, some couples can navigate that all on their own. Others look to books, podcasts, card activity decks. Some look to someone like me, a couples or a sex therapist. So we talk about grief and body image, having a kind of a clear and open dialogue with one another about how that's impacting the relationship. Communication, again, shifting from that caregiver role, addressing if there's any kind of built up resentment, or shifting in how we manage conflict. And then rebuilding that sexual relationship. So I realized after the fact that I could have shared these slides with you all, and I'm very happy to do so. So these are a bunch of questions of how to renegotiate some of those relationship things. So there's examples from, it says patient to partner, partner to patient, and both. And so a variety of different things, you know, is it okay if I touch you in this place, or this is how I want to be touched, that doesn't feel good, or, you know, so kind of negotiating in the moment. But you can also have these conversations outside of the bedroom, right? Where typically that's where the most pressure is. And so having those conversations ahead of time, maybe on a date night or something like that, where there's less stress about it, to be able to explain, this is how things have changed. This is maybe what I'm interested in. So in terms of exploring intimacy, again, things can change. You may or may not be interested in touch in the same ways. I've met a lot of women who just don't want to be touched anymore, and that's completely normal and reasonable and fine. It does have an impact on the relationship. And so being able to think creatively about, how do we experience pleasure together, even if it's non-sexual, even if it's non-physical, and try to take it very slowly, right? There's a reason that you might not want to be touched. There's a reason that you might not want to kiss or, you know, experience certain things, and that's completely fine. It's just being able to communicate that and then renegotiate again. What does that look like? Maybe it's kissing and cuddling. Maybe it's having that emotional closeness, or taking trips together, or doing something and having shared meaning. But having that common language to acknowledge, this is where we were, this is where we are, and this is where we're going. So I think the first line of treatment and recommendation, if you have these symptoms of vaginal dryness, pain with intercourse, that sort of a thing, are going to be the vaginal moisturizers and the vaginal lubricants. Both of these options are over the counter. I believe a lot of clinics have samples of them. I know my clinic does. There are different, I think the caveat that I would say is that in terms of the lubricants, there are water-based, oil-based, and silicone-based. We use them for different things. Typically, a water-based lubricant is going to be the easiest to clean up. It's not going to stain your sheets. It's not going to be damage sex toys if you use toys or dilators or things like that. They also tend to be absorbed quickest, and so kind of more tends to be better in that way. Lots of people prefer coconut oil, which is completely body safe and has that kind of antimicrobial benefit. But those are for in the moment. So they can last kind of minutes to hours. The vaginal moisturizers are typically a gel or an insert that is recommended, similar to a vaginal suppository. So it kind of comes in a little tube here. Let me kind of go over here for a second. So it comes in a tube or an ampule, and you will typically be recommended to start off doing it a few days in a row. You insert it often at night, so then like kind of before bed where you're going to be laying down, so it doesn't get really messy. And then you'll end up doing it 2 to 3 times a week. And that's supposed to moisturize the vaginal canal. So that's an internal option, whereas a lubricant you can apply kind of on your vulva, in the vagina, on your partner's genitals. It's really kind of whatever works for you. They are now making all kinds of products that have hyaluronic acid and other types of things in them. There's nothing wrong with them. There's been research that shows that sometimes there is an added benefit. My Good Clean Love and Yes, which are two that are shown here, are kind of fan favorites in that way. They don't have a lot of the kind of synthetic additives and things like that. If you are local to the Twin Cities, there is a really kind of public friendly sex shop called Smitten Kitten, and they have a bunch of handouts about pH of different lubricants. And so that's another factor. Not, if you go to Target or Walgreens, you might not have kind of the expertise where all of the employees there are kind of sex educators and very knowledgeable about that stuff too. Hormone therapy is controversial, I would say. Again, I'm not a medical provider to give you that information. However, if you are interested in talking about it, local therapy, so vaginal estrogen, whether it is a cream, a ring, or again, kind of that suppository, have been shown to be safe and effective for people with breast cancer. Systemic therapy has not at this time, understandably so, right? And so even if you are on a hormone therapy to block estrogen, this is still safe and effective to treat those vulvovaginal symptoms. I would talk to your oncology team. Generally speaking, every oncologist that I have talked to has said, yeah, of course, like that's okay. So, and that is something that is person specific. Some people are very nervous about that, but that is going to be the best benefit for managing those symptoms because it just puts a little bit of estrogen in the vulva tissue. Sexual aids are always a fun addition. So this one right here is called the O-nut. That is a barrier. And so if deeper penetration is what feels painful, right? So in terms of sexual pain, there's kind of two ways. One is kind of at the entrance of the vulva, which is usually kind of estrogen related in this circumstance. Otherwise, there's that deeper pain, which can be a variety of reasons. That is it's called a barrier or a collision tool. So that goes on a male partner's penis, similar to like a cock ring. It's super squishy. It's made of silicone and it can be stackable so that essentially the depth of penetration is less. They also make a version now that vibrates for a little added stimulation. Otherwise, there's a variety of different kinds of sexual aids to introduce individually or with a partner. Some of them are internal and external. Some of them are specific for clitoral stimulation and so on. Pelvic floor PT, I know I mentioned it. These are pictures of a couple different dilators. The light pink ones are typically a harder plastic, whereas the ones up above are more of a structured silicone and kind of more bendy. They can be very useful. Again, those are typically given out by a pelvic floor physical therapist, maybe somebody on the oncology team, but I think the caveat with dilating, similarly with Kegels, is that you want to have that assessment to know. So for instance, if your pelvic floor is already super tight, you don't want to be doing Kegels because then you're just kind of exacerbating the problem. And so really getting that assessment of somebody saying, this is what this is like, this is what you should be doing to kind of either stretch or tighten that space. In terms of resources, as I was listening to the nutrition one, I thought about a variety to add to this. So I work at the Center for Sexual and Gender Health. It is a clinic, an mHealth Fairview clinic, where we specialize in sexual and gender health. We have individual therapy. I run a women's sexual health after breast cancer group. Smitten Kitten is the store I was talking about. The following are two books that are really great. There's also a variety of podcasts. I know somebody had asked about apps. There are sexual health apps. The app Rosy, ROSY, has a sexual health and cancer module, which is really good. We have the pelvic floor rehab services. ASECT is the American Association for Sexual Educators, Counselors, and Therapists. Not all sex therapists have an oncology focus. However, they all, any kind of ASECT certified sex therapist would have a breadth of knowledge on treating sexual issues. And so that's a good place to locate a variety of providers. The Scientific Network for Female Sexual Health and Cancer is a small organization that this is the focus. There's a variety of webinars. The 2025, this is a shameless plug, the 2025 conference is here at the U. I'm the co-chair of that conference. And so while that is typically kind of provider focused, there are lots of patient advocates that attend the conference to get additional information and things like that. And that's all I got. I think I'm good.
That's perfect. Thank you so much, Dr. Girard.
Yeah.
Very, very helpful information. If anybody has questions, please feel free to raise your hand.
If a patient is interested in your services, what is the starting place? How to get connected with you?
That is a complicated question for kind of one reason. So at our clinic, a few years ago, when we had the joint venture, when we joined with Fairview, we were told that we could no longer have a wait list. That is the complicating factor. So we have about 12 full-time therapists. And so number one, you can call. However, if there's not openings at the time, the kind of party line is we'll just call back, right? And so, however, if you have we also have a referral in our electronic health records. So any person on your care team, if you're seen at the M Health Fairview system, can internally refer directly to our clinic. And so that tends to be, I think, the most successful way. So I run a sexual health group specifically for women after breast cancer. And that is, I work with one of the PAs in the survivorship clinic right now to try to have more access to sexual health services, because that has historically been a problem. Doing events like this, we're trying to do more educational events. But the group is something where typically a medical provider refers them to me. They typically send me a message directly and say, hey, I want this person in the group. Then you would meet with me for an hour to kind of establish you in our clinic. And then we say, okay, these are when the group run, which one would be beneficial for you.
And are the providers always on the side of the patient? Are there ever partners that get referred to their providers?
I don't get a lot of referrals from partners, although I could. Yeah, I could. And I've had a few referrals where both partners might have that history, or you know, I've done a lot of work with prostate cancer, and so I'll have kind of a combination that way as well. Yeah, I don't know if that answers your question, but I typically don't get a referral from a partner's provider, though I could. That would be totally fine, yeah.
Hi, does this type of therapy, this couples therapy, tend to get covered by insurance?
Yes. Our individual, couples, and group therapy are in general covered by insurance. Couples therapy is covered by insurance because it is family therapy. And so I say couples therapy to get the point across that it's two people, but we internally and in our records and in our billing, it's family therapy, and family therapy is always covered. If I billed for sex therapy, it would never be covered in any state, but family therapy always is, yeah.
So there's the couples therapy, and then there's the group. And I mean, both sound good.
Yeah. It really depends on the person and what their needs are. Right?
Okay.
And so I very much enjoy the group because it's typically, 8 to 10 women with 2 therapists, where we're talking about all kinds of different things. But I personally love to hear people who have had similar experiences get to talk to one another and hear, in the nutrition talk, people were sharing ideas of like, oh, I do this and that worked. And oh, I use this app. And I think that just that knowledge sharing and that camaraderie is so great. And so often the experiences are so similar, but we're so isolated. And so that's the benefit of their group therapy. People do both.
Your partner then is not there. So for
The-
me in a
Yep,
system, it would be the woman, I'm there, I'm learning all about it, and then I'm like, da, 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 to the partner.
Yes, that tends to be the case. Although generally speaking in these groups, what comes out of it is, oh, I wish my partner could hear this. I wish my partner could know this. And so we're trying to figure out how to adapt the group for partners. That becomes a scheduling issue for a variety of reasons, but that is a piece of it. Sometimes it's like, we'll do the group and then afterwards it'll be like, okay, so now what? Because the group is 8 weeks long. And so then it's like, okay, now what? And then maybe at that time they say, okay, well, now I want to do some couples therapy. Now I'd like to do some individual sessions to really process this thing I learned about myself in the group. And so there's a variety of ways that trajectory can go. For some people, they say, they try the group and say, that didn't really work for me. I didn't like the format or I didn't like the focus. I really want to focus on this one particular thing. And it's person specific, right? We started to do the group because we wanted to have more access to our services. And that was a way to get lots of people care when otherwise, if we don't have a wait list and a lot of our providers are full, my hope was to reach as many people as I can. And so my clinical work is, I think, 95% like survivorship sex therapy.
All right, thank you. We've got one last question here
Yes.
from online.
Yep, there were, first of all, just a lot of comments appreciating that this was a topic covered today. And then the question is, are there any groups for single or unpartnered survivors who are navigating dating and sexual health during and after treatment?
Not specifically. The group that we offer is not partner specific, and there are no exercises specific to engaging with a partner. It's all very much like focused on our own sexuality. Some of it is harder to do without a partner, but in general, I've run the group, a version of this group for about 10 years and had lots of people who are non-partnered in that group. And my colleague Tara and I, and probably you, are trying to figure out ways to expand survivorship services around sexual health. And so if there's a need for ongoing support groups and groups like that or talks, I'm more than happy to take up that charge to try to change the way our system works. So I think that a lot of people have indicated that they would like a space to come and just have more of a free form group to talk about what they're going through. And I love that idea. And in general, I'm supported by the clinic that I work at to try to do those things. And so I'm very hopeful that we will be expanding our services in a lot of different ways. Yeah.
I really applaud what you're doing, and I do think that as a person who's in their third year, topic might or might not have built my consciousness.
Mm-hmm.
And I can definitely speak for my friends that the day-to-day experience of breast cancer in this one, people just tend to think, oh, you're good now, right?
Yeah.
That last radiation method.
Yep.
And all this stuff is not. And I do believe that work you're doing is gonna help people continue to highlight the importance of what.
Yeah, I completely agree. And I think that what I notice is that for a lot of different types of cancer, the way things are moving are that people in surveillance and survivorship tend to be on a variety of different drugs for quite a while. And then we just forget about everything that's happening. And it's like, well, wait a minute. And I go to a lot of different cancer conferences. where I'm maybe the only non-MD, and all they're talking about is, oh, well, they lived 6 months longer. And I'm like, but what about how they're living? And so I have a real kind of bee in my bonnet about quality of life and kind of the longer term stuff, because it's so missed. So I will not stop talking about that. So.
Thank you, Dr. Girard. Thank you for that wonderful summary comment. Nothing more to say here.